I am Community Clo of Radio 1 Richmond stations. Thank you so much for joining us this evening. I'm so excited about it. It's something serious, but we can handle it. It's the Fibroid Friendship Hour with Richmond Vascular. And you know, I go to the source. You got Dr. McLaurin joining us here tonight. He's an expert in fibroid treatment who will lead our clinical discussion this evening. So for all of the folks who are joining us tonight, welcome, welcome, welcome. We thank you so much. We're so delighted that you're here. Now, the purpose of this event is we're here to discuss fibroid health and explore uterine fibroid embolization, UFE, as a treatment option. So I am so excited. When I think about me, and I had some fibroid tumors, and with age, they did shrink. But if I knew about UFE, I would have done it years ago with Dr. McLaurin, but we're here tonight. So let's start with the deepest of questions, Dr. McLaurin. What are fibroid tumors?
Well, thank you, Clovia. I really appreciate you having us tonight to allow us to have this conversation. It's a much needed conversation about a topic that really doesn't get discussed enough. Let's just jump right into it. Fibroid tumors are exactly that. They are tumors. They're tumors they're actually the most common tumor of the female pelvis. They live inside the uterus. They are made up of smooth muscle cells. They can grow anywhere within the uterus. They can grow in the wall of the uterus, underneath the surface. Underneath the lining of the uterus, underneath the surface. They can grow off of the surface, like on a little stalk, or even inside the cavity on a stalk. Now, these are extremely common, and in fact, most women are completely asymptomatic. They are just incidentally there and don't cause any problems. You could live your entire life and not have a single problem with them. And I think that's an important point to take home from this discussion, is that just because you have a diagnosis of fibroids doesn't necessarily mean you have to have anything done about them. But depending on where they grow and how big they get, they can result in a number of problematic symptoms. The most common symptom we see in our patients is very heavy menstrual bleeding. And this bleeding can be just completely debilitating and really affect a woman's quality of life and ability to do the things that she wants to do. And not only that, it can cause severe cramps, which also obviously can be very debilitating, and lead to missed work, missed family activities, and friend activities. And so those are probably the two biggest things we see. If the tumors get big enough, they can start to press on organs next to the uterus, like the bladder or the colon, resulting in urinary frequency or constipation. The fibroids can also grow in spots where it can cause issues with fertility and can prevent like a fertilized egg from implanting within the uterus. They can also cause bloating. Usually before the cycle starts, they start to feel a lot of bloating, and can also lead to back pain, leg pain, if they start to get so big that they press on the spine or the nerves going down the leg. And then I think a really important problem that fibroids can cause is the heavy bleeding can lead to anemia or a low blood count, and the anemia, I think, is really it's worthy of a discussion, for a moment, and that is where the patient's hemoglobin or iron stores get so low that they really their whole body, their whole body and their whole life can be affected by the anemia. It can cause fatigue and just really reduce their bandwidth to deal with everything that comes along in life. And it can be insidious, meaning it can happen slowly over, months to years, so slow that women just start to learn to deal with that anemia and that fatigue. And they're just like, well, I'm just tired, I'm just stressed out and tired. But it's not simply that. It's a medical condition. that usually needs to be fixed, and it can really change women's lives if we can get that fixed.
Dr. McLaurin, thank you for that. And for
Mhm.
all of our viewers tonight, whether it's women or husbands, significant others, when we're talking about the fibroids, the non-cancerous tumors, and you say, instead of doing something about it or having more conversations about the bloating and you don't know what it is and the fatigue, why is it that you think women don't share about it more and just deal
That,
with the anemia and other symptoms?
Great question. I mean, the symptoms that fibroids can cause are, like I said, debilitating. They can be, embarrassing, and discussing these sorts of topics can be kind of taboo for some people.
Mhm.
And that leads to, a lot of shame and embarrassment. And so people really just kind of stay quiet about it. And I've talked to so many patients who finally come to me and they tell me they've been suffering for a long, long time, and eventually they bring it up with their family and like say their mom or their sister or their aunt, and come to find out they had fibroids, and they just scratching their head like why didn't you guys tell me about this? And so and that's why we're here tonight, and that's why Fibroid Awareness Month exists, is so that we can talk about it more, so that there can be more awareness and dialogue, so we can get this addressed for more people.
Well, for folks who are just joining us, welcome to the Fibroid Friendship Hour with our expert, Dr. McLaurin. Now, we talked about the impact of the symptoms. We talked about fibroids. Now, let's introduce to our viewers, Dr. McLaurin, the UFE. What is uterine fibroid embolization?
Sure. So, uterine fibroid embolization is a procedure that I specialize in to treat fibroids. It is a non-surgical treatment where we are essentially blocking the blood flow to these tumors, that then over time they will shrink and the patient's symptoms improve. So there's no cutting involved. There's no, surgery, so to speak, to remove tissue. So it's all done in a very minimally invasive approach. It's done actually as an outpatient procedure in our clinic. It is significantly less risky than a surgery like a hysterectomy or a myomectomy, which we can talk about. The recovery time is so much faster than most other surgeries. We're talking 7 to 10 days versus about 6 to 8 weeks on average for a hysterectomy. And all the fibroids can be treated at once, which lends a very low recurrence rate compared to another type of surgery that does maintain the uterus. It's called myomectomy, where the gynecologist can go and actually remove individual fibroids. But that procedure has a relatively high recurrence rate. And compared to a UFE, it's much higher. So, and here we have on the screen kind of the spectrum of treatments for symptomatic fibroids, and it ranges from medication, surgery, and then this minimally invasive image-guided procedure, the embolization. And so a lot of women will start off being prescribed contraceptives, oral contraceptive medications, or this other medication called Lupron by their gynecologist that can help alleviate some of the symptoms. And it's obviously completely non-invasive. So there's no cutting or anything involved in taking a medication, but that it can help, but usually those medications are effective for a short term, and then the symptoms come back. And so then patients are usually being cared for by a gynecologist who usually only does surgery. And so the surgeries they talk to them about is most commonly hysterectomy, and then which is obviously removing the uterus in total,
Yeah.
which in this day and age I believe is usually unnecessary. We have so many other options for women, including UFE, where I think it's extremely important to maintain your uterus, if at all possible. We know that the uterus is not just an organ for childbearing. It plays many other roles in your body. namely supporting the pelvic floor health and maintaining the integrity of the pelvic floor. So,
Mm.
some issues that can arise after a hysterectomy that we don't really talk about either are things like urinary incontinence, vaginal prolapse. It can also lead to menopause. Even if they leave the ovaries behind and just take the uterus, it can actually incite menopause. It has been associated with decreased bone mineralization,
Mm.
like osteoporosis. There's also some association with cognitive impairment. And then not to mention all of the kind of self-identity as a woman is tied up a lot for many women in having a uterus. And so we want to keep that uterus around. It's very important. And not to mention all of the surgical risks like bleeding and infection and damaging organs around the pelvis when they remove the uterus. Other surgeries would be what's called myomectomy, which I mentioned before.
Yes.
This is where a gynecologist can go in certain patients and remove individual fibroids. Generally, this is done laparoscopically through little ports, and sometimes they have to do an incision like a C-section incision to go in and remove them. It's sort of more like an open procedure. And that can be effective and appropriate for some women, but and you are able to maintain the uterus, but again, surgical risks are similar to hysterectomy. Downtime is the same, and then you have a relatively high recurrence rate. So, and then there's some other options out there too. I think that's worth talking about, like Accessa. Accessa is another procedure done by surgeons where it's essentially placing these large needles inside of the fibroids and burning them with radio frequency energy. And that's a newer procedure. It's been around for a little while, and some of the gynecologists in Richmond do that. But that's a newer kind of option.
Mm. Dr. McLaurin, thank you so much. Now we're going to delve deep and we're going to talk about some of the case studies. What are we looking at here?
So this is just some diagrams showing how the procedure is performed, actually. This is showing two different approaches to doing the procedure. The procedure involves us placing a small plastic tube about the diameter of a spaghetti noodle, it's called a catheter, into one of the arteries, usually in the groin or in the wrist, as you see depicted in these pictures. Once we put that in, the artery, we use X-ray to guide that carefully down into the artery supplying the fibroids. And
Okay.
then with live X-ray, we're able to then deliver these particles, particles that are made out of a hydrogel. It's completely inert to the body. They are sized appropriately so that when they flow into the arteries going to the fibroids, they actually block up the arteries around the periphery of the tumor. So they're not going to go, through the tumor or go outside the tumor. It just goes right kind of around the edges, and then it blocks the blood flow. And then over time, well, I think actually we have a couple of pictures if you go to the next. Yeah, here we go. So this is just a cartoon that shows kind of before and after what we expect to happen. You can see on the left, that's before UFE. There's the fibroids are in tan and the uterus is pink. And then after UFE, you see those tan tumors have shrunken and the uterus is now more normal in size.
Okay.
So if we want to go to, yeah, we can talk about some of the case reviews here.
Yeah, let's talk about some of those.
Oh,
Maybe.
actually, Clovia, we could back up for just a second. I would like to talk about what puts women at risk for fibroids, because I'm sure some women may be wondering,
That's good. That's good.
yeah, yeah, am I at risk for it? So the truth of the matter is most women will develop, and we talked about that earlier, about 70 to 80% of women by the age of 50 will have them. Only about a quarter will have symptoms. Things that can lend higher risk is obesity, high blood pressure, smoking, diabetes, and we know that Black women are at significantly higher risk, 2 to 3 times higher risk than other ethnicities. Um, so, um, yeah, and then the other important thing is for Black women, the symptoms oftentimes are more severe than other ethnicities. They usually start at a younger age, tend to have larger uteri, and oftentimes more frequently anemic. And also it's important to note that Black women are offered more invasive treatment for their fibroids than other women too. So I think that's another reason to be having this conversation, is
Yeah.
so that more women know that there's other options out there than just a surgery, a very invasive surgery.
And as you said, if at all possible, let's keep the uterus intact.
That's right. That's
That's
right.
right. So, Dr. McLaurin, let's talk about diagnosing uterine fibroids. I see
Mhm.
this slide here.
Yeah, so this is a little picture here that I included just so people could get familiar with how we diagnose fibroids. Commonly, I'd say most commonly, fibroids are diagnosed by ultrasound in a gynecologist's office, usually at the time of a pregnancy or other sort of or other some other issue that a woman might have that she's seeing a gynecologist for. And so they'll see it and they'll say, oh, you got a fibroid. And that's a fine screening procedure, but it is not the gold standard, and you can really miss some things. When we are working patients up for potentially a UFE, we absolutely want to get an MRI if at all possible, because it shows the anatomy in so much more exquisite way. It shows us fibroids that you can miss. It can also show you other things that can coexist with fibroids that you can miss that are important to note. And so you can see on the picture here to the right, this is an MRI scan, and it's showing a woman's pelvis, looking at it from the side. So in the front, you've got the pubic bone, and right behind the pubic bone, you have the bladder, that white substance there, that's actually urine inside the bladder. And then
Wow.
behind the bladder, you can see the uterus. The uterus is markedly enlarged. It's very rounded, and then probably 3 or 4 times as big as it should be. And you can see how the uterus has gotten so large, it's actually pressing on the bladder. And I put a little frowny face there because the bladder is clearly not very happy. Not a lot of room for that to expand. You can probably imagine this person had some urinary frequency. And then when we do the procedure or do the MRI, we can see the exact number, exact size, exact location, where I can't tell you how many patients I've seen where they come to me and they say, oh, my doctor says I have 3 or 4 fibroids. We do the MRI scan and we see over a dozen fibroids. It's
Wow.
just incredible how much you see on an MRI.
Okay. Can I go into a question before we go to the next study, Dr.
Sure.
McLaurin? And we talked about it earlier.
Mhm.
This is a question from the chat. I had a myomectomy 5 years ago, which removed 23 fibroids, some measuring as big as a newborn's head. They have now returned. What would I do to be a candidate for this procedure? If so, what's the probability of them growing back?
That's a great question, and it actually represents a very common scenario that I run into in our clinic. Women who have had a myomectomy and then their symptoms come back. As I mentioned earlier, symptom recurrence after a myomectomy is relatively high. The number is about 11% per year after a myomectomy, so that adds each year 11%. So 3 years after a myomectomy, about a third of patients will have their symptoms come back. So when we see these patients, the first thing that we do is we order an MRI scan. We assess their fibroids to see, if they would be a candidate for the treatment, and then we can proceed to an embolization. Generally, with those patients, they usually are candidates. To be honest, I mean, obviously everyone's different. I'd have to look at the patient individually. But yeah, they most of the time they are candidates, um, and the chances of them recurring uh, after a UFE is significantly lower. So based on the large scale studies that were performed that validated this procedure. It shows that at least 90% of the patients got significant improvement in their symptoms, and at 3-year follow-up, 15% or less patients had recurrence of their symptoms. And I think that would hold true also for a woman who has had a myomectomy.
Yeah. Once you get the procedure, if your choice, Dr. McLaurin, is UFE,
Mhm.
and you continue to make lifestyle changes for the better, could that help in reducing the return of fibroids?
That's a great question, Clovia. It's a good point to make, is that we can do all sorts of medical interventions, and this doesn't only apply for fibroids. I mean, it applies for, high blood pressure medication or, high cholesterol medication. To really maximize the benefit, we need to also make lifestyle choices or lifestyle changes. And so that includes, healthy choices in what we're eating, and making sure we're active and we're exercising. We know that one of the things that drives, well, I mean, first of all, we don't know where fibroids come from. We do know what puts you at risk for them, but we don't know where they come from. But we do know that estrogen, the estrogen hormone that we get every month during your cycle, that is what drives their growth. And we also know that adipose cells, fat cells in our body, store estrogen. And so the more estrogen you have on board, the more fat you have on board, the more estrogen you have there. And so the more at risk you are for developing fibroids. So if we can make, even after a UFE or after a myomectomy, if we can work out and make healthful choices in what we eat, I think we can also maximize the results of those interventions.
Dr. McLaurin, thank you. I want to delve into more of the case studies and see what some of the results are. Can we
Sure.
do that?
I see a hand up, Maya.
Yeah, Maya. Oh, I'm sorry.
Good evening.
Maya, we love your questions. Let's go.
Hi, good evening. You mentioned that estrogen is a factor in fibroid symptoms and I guess, their growth, and how certain things like, exercise can help as well, as far as like reducing obesity and things of that nature. And we don't know what causes fibroids, but I was doing some reading and there were recommendations as far as like certain lifestyle changes that supposedly can help with, I guess, symptoms as far as like avoiding certain foods that have estrogen, like dairy, and also read that red meat. Are there other things that exacerbate those symptoms, or as well as like, I didn't know if like sugar or alcohol were also certain things to avoid, or what's your opinion on that?
Yeah, thank you, Maya, for that question. That's absolutely right. Like we said, estrogen drives the growth. So any of the meats that we may consume that have high levels of hormones, especially treated with hormones as they are raised, those can then we definitely want to avoid those. Dairy products are also known to have high levels of saturated fats, and so that can lead to more fat accumulation in our bodies. Also, hormones within the milk also can affect that. The sugars and alcohol, boy, that's a great point. I mean, sugar is so inundated within our diets, that just leads to that can lead to diabetes. Diabetes can lead to obesity. Obesity then can put you at risk for fibroid growth, and same thing with alcohol. Alcohol is terrible for your blood glucose and can also contribute to or exacerbate diabetes, and the whole cascade, as I mentioned. Yeah, great point. Also, I would be remiss if I didn't mention supplementation for vitamin D. We know that vitamin D is one of the most powerful anti-fibroid compounds that is out there. It's not a vitamin, it's a hormone. And studies have shown that if properly supplemented, it can shrink or prevent fibroid growth. So, and so many of us are vitamin D deficient that it's extremely important to get checked and supplement with vitamin D if necessary.
Is there a minimal recommended amount of vitamin D um, supplement that most people should try to aim for? Because there's so
Sure.
many different, when you go to the store, there's so many different bottles on the
Yeah, I
shelf.
know. And you have to be careful because, you don't want to take too much. Vitamin D actually can be bad for you if you take too much. It's the general recommendation is about 500, like the safe recommendation. You could probably, I hate to give, I really shouldn't give medical advice over Zoom, but um, the a generally safe dose is about 500 to 600 international units a day. You're not going to get in too much trouble with that. But I will tell you, if you get your vitamin D checked, um, it will likely be low, just statistically speaking.
Yeah.
And most of the time, you'll end up, if you're trying to get back up into the normal range, most people are going to end up taking like 1,000 to 2,000 international units a day, at least for some period of time. And then you can supplement with a lower dose, like 500 to 600 units a day, once you get back up to normal range. But that's something that really needs to be handled by your primary care doctor for sure.
Does that answer your question, Maya? All right. We're going to go on to a next question. What happens, Dr. McLaurin, to fibroids when they shrink?
Good question. So it depends on where they're located. So if you go back to the picture of the at the very top of the slide deck where it shows all the different locations of the fibroids, if you have what we call an intramural fibroid, a fibroid that's completely within the wall, or a fibroid that is on kind of growing underneath the outside surface of the uterus, when we embolize them, the first thing that happens is the fibroids soften. These tumors are extremely hard. I'm sure many women who have them can tell you, they can feel them through their abdominal wall. I mean, it is hard as a brick. And what happens is very quickly, I mean, I've even seen within, a month, these tumors are already softening. And then over time, they start to just shrink. The body starts to resorb that dead, devitalized tissue. And some of the smaller fibroids, if you were to take a MRI after the procedure, 3 months after, the smaller fibroids can actually vanish completely. You can barely tell anything was there. If they're larger, if they're softball size or something like that, then it's going to leave a scar behind. Is there a little dead zone that you can still see, but it's not actually viable fibroid tissue anymore. That's the most common effect that we see after an embolization. However, if you have what are called submucosal fibroids, the ones that grow underneath the lining, as you see there on that slide, those are oftentimes the ones that bleed heavily. Or if you've got one that's growing on a stalk inside the cavity, those can you can actually slough some of the tissue out during your cycle, or even between your cycle as you're healing. It's not that common, but it is something that I always mention to my patients, just to keep an eye out and don't be too scared if that happens. It's very it's self-limited. It goes away on its own, and usually isn't an issue. Occasionally, you can have patients with these what are called pedunculated fibroids, like they're right in the center, kind of growing off of a stalk. Those have been known to actually come out completely, like in one whole fibroid. Those are probably the more rare type of fibroids. And I've treated many patients with those types of fibroids, and it's extremely rare for them to come out, but I always mention it just in case. And usually they come out on their own, but there are instances where, we have to have a gynecologist help it out if it gets trapped in the cervix or something. But that's like a very, very rare situation.
Okay. Thank you for sharing. I want to head on back to the Q&A and in the chat. What is the impact on fertility chances after UFE invasive procedure, non-invasive procedure, that is?
Good question. So this is a very common concern, and so speaking specifically about UFE, I can't really comment too much on other procedures that are out there, except historically, myomectomy and UFE are generally the two procedures that women are considering, or women are offered if they are interested in fertility. Actually, it's been a kind of a myth out there that you can't get pregnant after a UFE, but I'm here to tell you women absolutely can get pregnant after a UFE. But many gynecologists will tell their patients, and it's on their websites even, saying that you can't have a UFE if you want to get pregnant. But women do get pregnant after UFE. Typically, the births typically the gestations are full term, and the births are vaginal, versus if you get a myomectomy, you have to get a C-section. There's no choice in the matter, because they violated the muscular wall of the uterus in order to do the myomectomy, and so you're at higher risk for complications during labor. So you have to have a C-section. So as far as the chances of pregnancy, it's all very individualized. It really depends on the patient and how many fibroids they have, where they're located, and it's really an individualized conversation about that, and one that we usually reserve once we finally get the MRI done, and then we can talk about, okay, what makes the most sense for you. And I try to guide patients to the best choice for them, and try to give them all the information they can. And I don't think you really can make a decision until you see the MRI.
You mentioned that, Acessa was one of the newer minimally invasive procedures that's sometimes talked about. How long has UFE been around as an option? Is it
much longer than Acessa. UFE's been around. It was first, quote unquote, discovered back in the mid 90s. That's when it was first published in the literature. And interesting story. The way this was discovered was gynecologists were referring patients for embolization to physicians like myself, interventional radiologists, to do the embolization prior to a myomectomy in order to reduce blood loss during that surgery. And what they found was they would do the embolization, and these patients would then no-show for their myomectomy. So then they started saying, why are these people no-showing? Because their symptoms went away. And so then that kicked off a whole many year process of really examining this procedure in a few well-designed randomized controlled trials. It's considered level 1A scientific data, and hundreds and hundreds of patients were treated, and showed the effectiveness and the safety of the procedure. And so that it was, early 2000s was when those studies came out and validated it. And then in 2008, I believe the American College of Obstetrics and Gynecology actually published an addition to their guidelines saying that this procedure, or that UFE, is a safe, effective treatment for fibroid and should be considered for treating fibroids. So it's been around for a while.
So basically, it was kind of like a happy accident.
Yeah, exactly. And this is something, embolization is not isolated to just fibroids. I mean, we embolize many different organs, including, livers and, kidneys, and if people are bleeding from trauma, we also do it for that. So it's a pretty non-specific treatment, but found that it's extremely helpful for this specific disorder.
And I had a couple, and if anybody else has questions, feel free to just jump in, but I have lots of
We
questions.
love it. We're here for it.
That's
Because
right.
I've been doing research. So, I want to make sure I understand the difference between Acessa and UFE, because it sounds like both of them are, you know, well, it sounds like most of the time Acessa is more of like a laparoscopic procedure where they're going in
Mm-hmm.
and providing treatment directly to each individual fibroid to soften them
Mm-hmm.
with, whatever type of procedure that's done. But UFE is going directly to the, I guess, the artery or the vein that's providing the blood flow to, like stopping the blood flow to the fibroid, which then would cause it to soften and shrink. Is that correct?
That's correct. Acessa, I should start by saying I'm not a gynecologist, and I don't perform Acessa, but I've also, of course, availed myself to all of the info out there. And from what I know, Acessa is a surgical procedure done, and so you have to be put to sleep under general anesthesia, usually done laparoscopically, although it can be done hysteroscopically, meaning instead of going through the abdominal wall through incisions with a laparoscope, they can, depending on where your fibroids are, like say it's a submucosal fibroid, they can go through the cervix using a hysteroscope and putting the needle, the probe into the fibroid that way. But I think most of the time, probably it's done laparoscopically. And then what they do is they visualize, with the laparoscope, the fibroids, on the surface of the uterus, and then they put the needles in, activate it, and then I actually do ablations on other tumor types in the body, like liver and kidney, and we use the same kind of tools using radiofrequency ablation. And what it does is it basically burns and chars that tissue to then make the tumor shrink. It actually, you can watch it as it shrinks. It's pretty impressive.
Wow.
But it's sort of like any sort of selective procedure like a myomectomy, Acessa, you've got to be able to access that tumor. And if you can't access it, if you can't see it, then how do you treat it? So I think that's one limitation of that procedure. And also there's probably a limit to how many they can get to. But from the data I've seen, I think the downtime for Acessa is uh, significantly less than a hysterectomy or a myomectomy. Um, but it's still, still significant. And the recurrence rate after Acessa has been published as relatively low. So, I mean, I think for some patients it's a decent option, and something that I definitely encourage patients to talk to their gynecologist about. But one thing that I've noticed, at least here in Richmond, is that it's not every gynecologist does it. I mean, there's very few that I know. I actually know probably one by name that does it. So it seems like it's not that widely available.
Dr.
Right. Well,
McLaurin, I kind of wonder if, as a result of Acessa being so new, if long term they're not going to see some of the same challenges that myomectomy has in them growing back, only because the difference with UFE being that you're blocking that blood supply, and so they can't grow back, right? Or they shouldn't grow back. You might get new ones in different places, but the fact that you're blocking the blood supply, where the other procedures are kind of trying to either take them out or whatever, but they could still grow back.
Yeah.
Is that kind of the right
Yeah.
thought process?
Well, my thought is, so they've obviously done some studies on this. I think the studies that I've seen, the recurrence rate um, is actually not too bad. It doesn't seem as bad as myomectomy, but I need to delve more deeply into those studies. I think the the downside of Acessa is similar to myomectomy in that the reason that myomectomy recurrence rates are so high is that they leave fibroids behind. Okay. So if you leave them behind, what those do is they continue to grow and eventually cause problems down the road. Same thing with Acessa. You've got to be able to find all the fibroids. And if you don't get one, then that one's going to continue to grow and cause problems. With UFE, we are able to treat every fibroid. It doesn't matter how big or small, even the tiny little like microscopic ones that you might. So here's a great example of it. Even the small ones we can treat. Whereas like how are you going to see a tiny 2 centimeter fibroid that you can't feel or see within the uterus, laparoscopically, you can't treat it. So then those continue to grow and then cause issues down the road. But this is a slide just showing how vast the spectrum of problematic fibroids can be. You've got a lady on the left that's got her entire abdomen filled with fibroids. Obviously, that's a problem. But then on the right-hand side, you have a lady that has just one single fibroid that's submucosal, just in the wrong place. So both of these women can be treated with UFE. It's impressive to me, like how many of the patients I see end up being a candidate for the procedure because it is so widely applicable.
I'm really curious, since fibroids are so common for women after a certain age, like I think you said 70% by the age of 50, and it's 2 to 3 times more common in women of color. Why are more, and you may not have the answer to this, but I'm just curious if you had an opinion as to why it is more gynecologists aren't doing any kind of like regular screenings for women. When you can clearly see someone who maybe looks like they're 6 months pregnant and there's no baby, and they're complaining of symptoms. Because, like, I know for myself personally, I've been having symptoms for probably, when I think about it, probably close to 20 years, and was a person who was very vocal and speaking out about certain things, and was basically being gaslit by my doctors over the years, and only because I'm a person who, is persistent and did research and did this random online quiz and started learning about fibroids, was then able to go and be very persistent and say, yes, you're saying everything looks normal, but I want an ultrasound to rule this out. And then they're like, oh, yeah, there they are. Like, why, I'm like, why?
Well, I mean, that is, you make such an excellent point here. It is something, and it's a story as old as time, it seems like. Women, and unfortunately, women of color often are disregarded. Their symptoms are disregarded and they're not taken seriously. And so you end up having people who just are being gaslit, and they just say, well, I guess this is just normal. And that's what I'm here to say is that, bleeding through your clothes, not normal. Having clots the size of a golf ball, not normal. And I mean, we have to just talk about it more. And I think that oftentimes, I mean, I don't know, maybe gynecologists feel like their options are so invasive and they are risky, that maybe they would rather reserve it for when it's just you're at death's door or something. I don't know. I mean, I feel like and honestly, that's what kind of pushed me to start doing this, is that I saw issues arise after hysterectomies with patients in the hospital that I was working in. And I just thought to myself, I have something better than this. And so I felt compelled to start talking about it more, because I found out that there are so many women just dealing with this in silence. And it is a combination of, a lot of it is, probably sexism and healthcare discrepancies based on, race as well. So.
Yeah, it's very frustrating and infuriating because, as the patient / consumer, you're supposed to be able to have faith and trust in the person that you're going to for medical care. And in my case, like I said, I feel like I've been gaslit for basically 2 decades. And then once I finally pushed and got this diagnosis, it was still very frustrating because I'm asking, I'm a person who does my research, and then I ask, hey, what are all of my available treatment options? UFE was never mentioned as an option. Even Acessa initially was not mentioned as an option.
Yeah.
I did more
Yeah.
research and found a doctor in the same practice who did do a SESA, had a
Hmm.
follow-up with that person who was still even hesitant to do that. Everyone kept pushing the most
Yeah.
extreme,
Yeah.
which is a hysterectomy. I'm like, no, this is not acceptable. And it just so happened that a friend of mine heard a radio ad about, you know, this procedure at UFE and
Oh, that's great.
Richmond Vascular Center. So I'm just like, why? We need more people to know about this because it's
Yeah.
just very concerning and troubling to me that if I'm asking a doctor straight up, what are all of my available treatment options? And you're not telling me all of my available treatment options. If I'm a person who doesn't do my research, then I'm not truly making an informed decision that's in my best interest.
I mean, I want to just double click on that, as they say. Yes, I am a big believer in informed consent. I mean, informed consent is a pillar of medical care, and I think that it's not right for you not to be informed of all of your options, and it is extremely common. Your story is a carbon copy. I've heard this so many times. And just here's a stat for you. There are approximately 600,000 hysterectomies performed in this country on an annual
Wow.
basis. And about 300,000 of them, half of them are being done for benign causes like fibroids. So it is just, yeah, it is just reflexive. Oh, you have problems with your cycle. I know how to fix that. Take it out. And it's just, I think also there's been an underappreciation over historically of what happens to women's bodies after hysterectomy. And people think, oh, you don't need that. It's like a throwaway organ,
That's
like an
definitely the
appendix.
tone that was used with both
Yeah.
doctors that I discussed it with, and it was disgusting to me and it angered me.
Yeah, yeah,
But as you're
exactly. And that's
talking about more, when you say it, we want to keep the uterus intact, but it just doesn't serve one purpose to carry a baby.
hmm
When
yeah,
you mentioned it earlier, so it's more to it than just carrying a baby.
exactly. It's really the foundation of your pelvic floor. If you think of it like just simply as a support uh, organ, I mean, it's a huge thing. And to go in there and just remove that is just yeah, and I know plenty of women that get through it just fine, but then I know a lot of patients who've had issues, and I've talked to patients who come in for a UFE consult, and they tell me, yeah, my mom, she had a hysterectomy, and she's had all of these subsequent issues, and that's why I'm here, because I don't want to go down that road. So it definitely happens. And then just the insidious stuff that we don't is underappreciated, like the bone health and the hormonal changes and potential cognitive impairment. I mean, this is stuff that does worry me a lot. So it's better to, especially in 2024. I mean, come on, we should be able to do better. One case study I wanted to show, I think it helps to see kind of the start and finish of how our patients recover from UFE. This was Jane. She was a 48-year-old woman that had a history of uterine fibroids. Her main symptoms were very heavy, painful periods. They lasted 4 to 5 days. Usually on day 3 was the heaviest. She was having to use both a pad and a tampon, changing every hour, and she was passing large clots. She also reported bulk symptoms, including chronic constipation, pelvic fullness, and painful intercourse. The picture here on the right side of the screen shows her MRI scan, and it shows her uterus is enlarged with a large fibroid there at the back part of the uterus, in the top back part of the uterus there, almost contacting the spine, as you can see. So you can understand how why she's having sort of those bulk related symptoms. Then she underwent a UFE with us, and on the next slide, you can see here we saw her back at 1 month. The first cycle after the UFE was lighter. She had no pain or clots, and she had no significant changes in her constipation or other bulk related symptoms at that point. But then once we saw her at 3 months, she said the cycles had become much lighter. The constipation and pelvic fullness also had improved. And so you can see the pre and post UFE MRIs there. On the right-hand side, that's 3 months after. We got an MRI scan that shows the uterus has significantly decreased in size. It's now basically normal size. That fibroid is now basically vanished. And so you can see her abdomen is much less full. And so she was feeling a lot better. This is another lady that we saw several months ago, where she's relatively young, 37 years old. She was diagnosed 10 years ago with fibroids that caused heavy, painful periods, lasted 5 days. Day 2 to 3 was the heaviest. She would have to wear an overnight pad that she changed every 1 to 2 hours, and had large clots. She was also significantly anemic. She was having to take iron supplements, and she also had dramatic bulk symptoms. Her abdomen was distended. She told me that, family members and friends and just random people that she would encounter in her daily life would ask her about being pregnant. And in addition to that, she had chronic constipation, and I think she also had some urinary frequency too. And so on the next picture, you can see what she was dealing with here. On the left-hand side, this is her MRI scan, which shows her abdomen looks protuberant. It's being pushed out in the front by this extremely enlarged uterus that's about the size of a 6-month pregnancy at least. You can see her bladder in the front is sort of compressed by the uterus. And I mean, her uterus is spanning from her abdominal wall all the way back to her spine. And then on the picture to the right, this is a picture from the front of her body. So you can actually see her hip joints down on the bottom there. That's her right hip, and that's her left hip. And you can see how far left to right the uterus spans. Essentially, her whole abdomen was filled with this fibroid uterus. I honestly wonder where all of the other organs that are in there, where they go to, because they really don't have any room when it's occupied with so many fibroids. We ended up offering her UFE. She did do the UFE after the procedure. She had the typical experience with lots of pelvic cramping that started right after the procedure. She did have some nausea and vomiting the day after the procedure, which is very common, but that resolves quickly afterwards. And then we saw her back at 1 month. Her first period after the UFE was much lighter with decreased clots, but the period did last for a few extra days. She had some spotting, and her period cramps were much improved, and her pelvic fullness and constipation were also already improving even after just 1 month's time. Then we saw her again at 3-month follow-up, and at that point, she was over the moon excited. She was very happy. Her periods had become so much lighter and shorter, no clots, minimal cramps, and her abdominal distension had actually gone away. It was very impressive, and I was so happy for her. And her constipation was completely resolved too. But yeah, it was one of the most impressive follow-ups I've ever had, and I was just so happy to see her doing so well. And so, as we mentioned before, the expected results after a UFE is that at least 90% of our patients will get significant improvement in their symptoms, very low recurrence rates. And that's based on the large-scale randomized controlled trials that were performed several years back that validated this procedure as a treatment for fibroids. But we also track these symptoms and how they improve or don't improve within our own clinic. All of our patients get surveys for these symptoms before and afterwards. And so here's some data that shows actually Richmond Vascular Center's results. So you can see after 30 days, or I'm sorry, after 3 months, 80% of our patients say the cramps and pain have improved. 89% say the heavy bleeding is improved. 93% say frequent urination has improved. 84% fatigue is better. and 84% say cycle anxiety is better. So we get very very similar results as what was shown in the large scale studies.
Good. Any other questions before we go? I don't see any questions in the chat. Maya, do you have another question?
One small question.
Sure.
I know you mentioned earlier in the program that when you do the UFE procedure, there's two different places where you choose to go in. One was the groin, and I guess the other was like your arm, somewhere in the arm or the wrist. How do you decide which location?
That's a great question. Not everyone is a candidate for a wrist access. Nearly everyone is a candidate for a groin access. That's the quick answer. The wrist access really has to do with the artery size and certain. We have to make sure you have the right kind of anatomy within the hand. It's definitely a newer way of doing it, and I think the only true advantage of the wrist access is there's some studies that show that patient comfort is better with the wrist access. But for me personally, my advice to patients is, and I'm comfortable with either approach. My advice is that unless there is some major reason why you can't use the femoral artery in the groin, I would go groin, because there's a lot of branches that other artery branches you have to pass in order to get down to the uterus from the wrist. And like I said, I can do it, and I've done many cases this way, and I will do it if I have to. Some patients just have like either skin problems in the groin, or morbid obesity also is another one that might increase the risk of a groin access. But most of my patients can get by just fine with a groin access. My thing is, this day and age, we're all using our hands. We're all using phones to type, our keyboards to type for our jobs, and we use our hands for everything. I would hate for anything to happen to someone's artery going to their hand if we had a complication. I've never had a complication, but it is something that does concern me. But I reserve it in the options that we have if we need to do it.
Okay, I was just curious because to me it looked like the groin was a simpler path.
Yeah, exactly.
I was thinking it too, because I'm like, this is a long travel.
Yeah, it's like initially I thought, oh, this is a very elegant way of doing it if you can do it through the wrist, because then you just kind of put your arm out and we just do it right there, and all roads lead to Rome, so as they say. Yeah. So I mean, I can get to the uterus from the wrist, but yeah, it is a lot closer. There are a lot of tools that have been developed, since over the past 25, 30 years for this procedure, and they're all geared towards that kind of groin access. So I don't find the need to really change it up routinely, but I will sometimes if patients really want me to avoid the groin puncture, or have other issues that prevent the femoral access.
And typically, how long does a procedure take? Like, say someone only has maybe like a handful, maybe like, let's say maybe 3 or 4 fibroids that are smaller than 3 centimeters. If you had to estimate, like, how long would a procedure take from start to finish? Because I know you said it's an outpatient type procedure.
Right. So I can tell you just from the procedure, from me walking in the room to walking out of the room, the procedure is going to take less than an hour. It'll be on average about 45 minutes.
Really?
That's right. Yeah.
Wow.
So, and sometimes shorter. But it usually is dependent, like you were alluding to, about how extensive the fibroid burden is. The bigger the uterus, the more numerous the fibroids, it can lend a little bit longer, but on average about 45 minutes. And then it's the whole process during the day is a lot longer than that, because there's the prep beforehand and then the recovery afterwards, but the actual procedure time is only about 45 minutes.
Thank you.
Well, that's going to pretty much do it. And thank you so much for all of the questions in the chat. Thank you so much, Maya, for your questions. I just love it when we ask questions. Smart folks ask questions. So once again,
Great.
thank you so much for joining us this evening. Our special guest for this Fibroid Friendship Hour. I am Clovia Lawrence. Thanks for listening.